I think it's important to talk about malignancies in pregnancy anyway, because I think it's a subject that have not been addressed really very well over the years. Plus the fact I feel personally that more pregnant are having, conceiving at later age these days. So I think because cancer incidence increase with age, we are going to encounter these problems and it needs to be addressed. Luckily, it's uncommon. So leukemia occurs in about 1 in 75,000 to 1 in 100,000 of pregnancies. However, acute leukemia represent the majority, and acute myeloid leukemia represent 2/3. They can present at any stage of pregnancy, and this is why I addressed during my talk all stages of pregnancy and how to approach it, because the approach is different during the first or second and third trimester. Diagnosis of malignancy or acute leukemia during a pregnancy poses a huge challenge to the mother, to the family, and to the medical team, because you have the well-being of the mother as well as the well-being of the fetus to look after. You need to fully inform the mother about the diagnosis, the complications of chemotherapy on baby and fetus. And this is why you need to have really a high suspicion of acute leukemia before embarking on further invasive investigations. And I advise that people will do the essential investigations. And with that, they need to do a blood film. And of course, circulating blast on a blood film is an indication of sinister bone marrow pathology. And I advise when they do the bone marrow pathology, the bone marrow test, they need actually to take all samples at once. And samples for morphology, flow cytometry, immunophenotyping, cytogenetics, and molecular analysis. And that will help them actually to more accurately define the subtype of acute leukemia, which will have a huge impact on the prognosis as well as, treatment. What appears to be is that administering chemotherapy during first trimester is unlikely going to end up with a healthy baby. So there is increased incidence of miscarriage, fetal death, and fetal malformation during first trimester if you administer intensive chemotherapy. And that's the difference between acute leukemia and other type of hematological malignancies like chronic myeloid leukemia or lymphoma. Acute leukemia is a fatal disease, and delaying a treatment for 3 weeks can kill both mother and baby. So you need to make a decision fast. So during the first trimester, we think it is very unlikely to deliver a healthy baby. And the advice to the mother is to have medical termination. But of course, you need to respect the wishes of the mother, and you need to inform them about the risk. Risk of malformation, risk of death. Second and third trimester is a different story. You can administer chemotherapy relatively safely during second and third trimester. It seems to be less associated with malformation than from the animal data compared to the animal data. So human data seems to be associated with no increase fetal malformation during second and third trimester. But there is still association with a small gestational age baby and a premature delivery, as well as a neutropenic sepsis. And that need to be addressed and can be avoided actually. No, it's not that different, but however, we need to, advise about the safety of the agents we are giving during a pregnancy. So the standard treatment in the UK is a DAR chemotherapy, and this is a combination of daunorubicin and cytarabine. And daunorubicin given day 1, 3, and 5, and cytarabine twice a day for 10 days. In Europe, they use a 3+7. So DA3+10 or DA3+7 is the standard treatment for acute myeloid leukemia, whether it is here or in Europe. And it can be administered to a pregnant woman as you administer it for non-pregnant women. And we do have safety data associated with these drugs, so we can, safely advise about the use of these agents. But as I said before, there is still association of small gestational age babies as well as prematurity. I think it's very important to have all other supportive cares, and we start with the psychological support to mother. during, first time at diagnosis, because they need, a lot of support to make their decision. And the dilemma pregnant women faced with at gestation when delivery is not an option is a huge. And the second thing, other supportive therapy will be, of course, the antiemetic therapy I gave advice on. I gave advice on types of antibiotics and which one is safe, which one is to avoid, and that is very important. And the nice thing about it is that you can apply it to all other malignancies when it comes to supportive care. The most important part of the supportive care would be the treatment of sepsis, because you can save lives by treating sepsis. So identifying sepsis in pregnancy is tricky, because first of all, pregnant women are more susceptible to infection than non-pregnant women. And second of all, they don't present with the typical symptoms and signs of infection. So you need to have low threshold for suspecting infection, starting antibiotics as soon as possible. And of course, if they present with premature rupture membrane, you need to cover with antibiotics. During delivery on rupture membrane, antibiotics cover should be there. So sepsis, I would say, the most important complications during pregnancy that can be treated promptly and prevent both maternal and fetal death. I think it is different, because chronic leukemia do not possess, an immediate risk on mother and baby's health like acute leukemia. Like I said before, if you don't treat it within a couple of weeks, you can lose mother and baby. That's first thing, because it is acute, aggressive type of leukemia. The second thing is that the treatment for it is aggressive treatment. So it is intensive chemotherapy, and it is going to pass through the placental barrier. And the baby will be neutropenic at the same time when mother is neutropenic. So the baby is going to have some dose of the, a proportion of the chemotherapy you are administering to mom. And this needs to be taken in consideration. I think when it comes to like chronic leukemia, treatment for chronic leukemia does not cause neonatal or fetal neutropenia. I think the messages to take home, first of all, yes, you can administer chemotherapy relatively safely during second and third trimester. So if they present during second and third trimester, you can start chemotherapy and continue with the pregnancy. However, if they present at a stage when the baby is mature enough, say after a 28-week gestation, then you can deliver the baby and then continue with the chemotherapy afterward. The second message is that you can save lives, both mother and baby, by treating sepsis. And the third message would be the timing of delivery, because you need to time the delivery at a time when mother is not neutropenic, and that should be at least 2 to 3 weeks post-chemotherapy. And this is to avoid delivering at the neutropenic stage when mother can be exposed to sepsis, but also as well the baby will be neutropenic and will have neonatal sepsis and death. And it seems to be really a high risk.